Lymphoma. What does that mean? Everybody, I think, identifies lymphoma with the disease, but I want to look a little bit at the derivation of where the word comes from, because I think that helps us understand what it is. And lymph is a little bit more complicated, so I'm going to cover that next. We'll do the oval part first, because that's pretty simple. It just means a marked growth or a tumor. Okay, so it's a mass. Some examples are a lymphoma, which is a fatty tumor, neuroma, which is a nervous tumor, so it starts in a nerve cell, and it's a tumor. A carcinoma, which just means a cancer mass. And lymphoma, okay, so that's something from the lymph system that is a mass. Lymph is a little more complicated because it's not a single cell or organ. Next slide. The lymphatic system is made up of a bunch of different components throughout your body. The most important component are lymphocytes. And those are cells that help to fight infection. These lymphocytes circulate throughout your body, and they go through all these lymphoid organs. So there's the bone marrow, where these cells start and where they are made. There's the thymus, which helps to train these cells. You have lymph nodes throughout your body. You have your spleen, which is up here, in case you ever wondered. Spleen's on the left, liver's on the right. And you have tonsils and adenoids, unless you've had those taken out before. Now, most of these things other than the bone marrow, you can take out, okay? So they're not absolutely necessary. You can take your spleen out, you can take your adenoids out, your tonsils out, and the rest of your lymph system will take over for the most part. You also have parts of the lymphatic system throughout your digestive tract and your respiratory tract. And these lymph cells circulate around and do the work that they need to do to fight infection. Next slide. So, when patients develop lymphoma, the most common thing you'll notice are enlarged lymph nodes. But people will also have what we call B symptoms. And those are symptoms of night sweats, weight loss, and fevers. Sometimes these masses aren't that obvious because they're places you can't see them or feel them, but you will then develop abdominal pain or chest pain as these masses get bigger. Next slide. So now I want to start to give you a historical perspective of where lymphoma was first recognized, and it's important because it has defined a lot of the ways we classify lymphoma and how we understand it. Back in 1666, a guy named Malpighi first described clinically what happens with lymphoma. But really the first succinct description of it was in 1832. A guy named Thomas Hodgkin talked about a type of lymphoma. It started in the chest, and then it spread through the lymph nodes. And in some patients, when it was very advanced, it involved the spleen. Next slide. In 1898, a doctor in Baltimore at Johns Hopkins and another in Germany, that same year, they both identified this cell. This is called a Reed-Sternberg cell, named after those two docs. And this is the cell that was associated with Dr. Hodgkin's disease. Okay, so that pattern of spread and that type of lymphoma is now defined by these cells. So when you see this cell under a microscope, you can say that person has Hodgkin's lymphoma or Hodgkin's disease. Okay? This is called a Reed-Sternberg cell, and it's also called a fried egg cell. And if any of you were planning on going to medical school, remember this cell because it's always on some test. Okay, this is like the one thing where you need to know to sign your name, and you don't ever miss the Reed-Sternberg cell. You get a little flashcard, Reed-Sternberg cell, Hodgkin's lymphoma. Okay, they call it a fried egg cell because it has the center here, so it looks like a fried egg. This would look more like pepperoni with a middle of it in, but that's what they look like, and that means that you have Hodgkin's lymphoma or Hodgkin's disease. Next up. So it's a pretty rare disease, really. There are about 3 cases per 100,000 population per year. It's less than 1% of the cancer cases in the U.S. There will be predicted to be about 9,000 cases in 2012 and about 1,000 deaths in 2012. Next slide. So why do we care? It's a pretty rare disease. Why do we all know about this disease? Why have we all heard of it? And why is it's so popular in the press and you hear about people with it all the time? Part of it is it affects young people, okay? So when people are very elderly and they get cancer, you don't hear about it for that long. When people are very young and they get cancer, especially if you can cure it, you hear about it for a long time. And this is a disease that primarily affects people ages 15 to 34, although it can also affect, there's a second wave of the distribution after 60. And it is historically significant because it's one of the few diseases that for over 100 years, the definition is the same. So how many people here have had the grip? Well, one person thought about raising it. Okay. Nobody gets the grip anymore, right? It's a disease that you had 100 years ago and now it's gone. Most of the diseases that you have now, they're no longer, they weren't, we didn't know what they were 100 years ago. And this one, since 1898, is unchanged. So it's one that we've been able to sort of track our progress with and define succinctly for a long time. The other reason it's significant is because it is very sensitive to radiation and to chemotherapy. Okay? So, next slide. This was the first Röntgen ray, or X-ray, that was ever taken. This is somebody's hand with a ring on it. And when radiation was first, I'm not going to talk about radiation in this graphic, but early on with radiation, people figured out they could take pictures, and then soon thereafter, they sort of started radiating stuff to see what it would do. And people with enlarged lymph nodes, when they would radiate them, they put literally some radium up next to it, they would shrink. And it was the first time that we thought, maybe this could be helpful for lymphoma. And as time went on, as we all know, radiation devices got bigger and bigger. Next slide. And we got more effective at treating lymphoma with radiation. And people who had small areas involved in lymphoma, some of them we cured with radiation. And as time went on, we also realized that some of the people that worked with radiation, and some people who are exposed to high doses of radiation, seem to be getting more lymphoma. So there also seems to be a relationship both from a treatment standpoint and potentially from a causative standpoint. Next slide. Another important thing happened when we got to 1940, and that was the development of other toxic things that were not meant to treat people in a nice way. Things like mustard gas, which was designed as a weapon. Next slide. But it kind of backfired. In 1942, there were a bunch of soldiers on a boat that got sunk, and it had mustard gas in it. And when they got out of the water and came back and went to the hospital, their white cells, which are lymphocytes, okay, so they disappeared. They went away. And a lot of leukemias and lymphomas are too many white cells, and people thought, well, maybe we could use this to treat patients who have too many white cells. Next slide. So in 1942, one patient got exposed to nitrogen mustard as an experiment. And it kind of worked. So this was somebody who had lymphoma. Lymphocytomas don't work. But they had lymphoma, and they had been treated with x-rays, and it no longer worked. So they then gave that patient nitrogen mustard. And it worked. Sort of. Didn't cure it. But it shrank it for a while. But they didn't publish this till 1946 because it was considered a war secret. So it didn't get published until for another 4 years. Next slide. And as we found individual drugs that seemed to shrink lymphomas, two docs, Goldie and Coltman, came up with this idea that now seems kind of obvious, but back then was revolutionary. And that was that as you treat a cancer with a certain drug, it's going to get more resistant to that drug. And that all tumors are going to develop that to some degree. So instead of letting these tumors develop resistance, you should just hit them with everything all at once. Which can be really rough on patients, okay? So early on, it wasn't that rough because we didn't have any drugs. We get 2 drugs. But then as we developed more drugs, it got more and more difficult to do that. And patients got sicker and sicker. Next slide. But as we experimented with giving patients multiple drugs, we met with quite a bit of success. So in the early 60s, 14 patients got a combination of 4 drugs: vincristine, methotrexate, cyclophosphamide, and prednisone. The drugs themselves aren't that important. The key thing is that we were giving people multiple drugs, and it worked much better than single drugs. Okay? They were getting lower doses of these drugs, but the combination of multiple drugs worked much better. Next slide. And we got newer regimens, MOB, in the 1970s, which was cyclophosphamide, vincristine, procarbazine and prednisone, was a revolutionary combination. 81% of these patients had their disease go completely away as far as we can tell at the end of their therapy. Okay? So with single agent drugs, we're talking 20%. So people were ecstatic when we were shrinking some of these tumors. Now all of a sudden we're shrinking the vast majority of them. Next slide. And if you look here, you know, other doctors make fun of oncologists because they say, well, all your curves go like this. Right? So this is what percentage of people are alive, and this is time. Okay? So this is with single agent chemotherapy or untreated patients. Okay? 100% alive at the beginning, 5 years later, essentially nobody. Okay? This is that trial with mom. 4 years later, 60% of patients, more than 60% of patients still alive. Next slide. And here, when you chart that out farther, durable remission, over 60%, 20 years later. And this was the first time that we'd ever really, there's a separate story that maybe someday I'll talk about testis cancer, which is super exciting, especially from Indiana University. But this was a revolutionary thing, okay? A disease that was uniformly fatal. Now 60% of these people are living long term. Next slide. As time went on, we looked for less toxic chemotherapy. And this is what, for Hodgkin's disease, has become sort of the standard chemotherapy, ABVD, which is adriamycin, bleomycin, vinblastine, and dacarbazine. It is still a rough thing to go through, but it works a little bit better than MOM. It is less toxic, and the vast majority of patients with Hodgkin's disease, that's what they get treated with. There are some exceptions to that, which I won't go into, but this is sort of what's become the standard of care for Hodgkin's disease. Next slide. So if we know how to treat it pretty well, where does it come from? That's the next thing. You know, if you can treat it, what you really want to do is prevent it from happening. And we don't totally understand what causes lymphoma, but we know there are some things associated with Hodgkin's lymphoma, okay? So there's mononucleosis, or Epstein-Barr virus. People who've had mono or EBV infections are more likely to get Hodgkin's lymphoma. Aspirin seems to be protective. Smoking increases the risk. Don't smoke. We know that clearly is bad. And it has not been associated with radiation exposure. Next slide. I know this is a very sophisticated crowd, so I have to completely redo all of my jokes. Okay, next slide. So, the problem is Hodgkin's disease got so famous that everything else got lumped together. Okay, so there is Hodgkin's lymphoma, where there's a fried egg cell. We know how it works, we're good at treatment, and then there's everything else got lumped together as non-Hodgkin's lymphoma. So, that's this. Purple in medical school, at the very beginning, you learn purple's bad. A lot of purple in a slide under a microscope, it's not what you want. A lot of purple there, that's bad. Okay, next slide. To give you an example of just how many lymphomas there are, this isn't how many lymphomas there are. This is just the classification systems for different lymphomas. So my worst nightmare is people call me up, hey, how you doing? You know, I haven't been talked in a while, but my uncle has lymphoma. What does that mean? What kind of lymphoma does he have? I'm not sure. Doesn't mean anything. There's so many different kinds of lymphoma, and they're so different that that's an impossible question to answer. Next slide. I want to talk a little bit about where lymphomas start and where lymph cells start. So this is a stem cell, and what stem cell means is it's a cell that can become a whole bunch of different things. Okay, so these live in your bone marrow, and they can become blood cells, red blood cells, which carry oxygen, platelets, white blood cells, or lymphocytes, which circulate throughout your lymph system that we talked about a little earlier. So this lymphoid progenitor, or early lymph cell, can become a B cell, or a T cell, or, my favorite, the natural killer cell. Sounds kind of tough. Next slide. We're going to concentrate only on the lymph stuff because we're talking about lymphoma. So T cells, they release things called cytokines, which help tell other cells where to go and what to do to fight infection. B cells, they produce antibodies. And antibodies are things that attach to the surface of a cell and mark it for destruction, in the same way you might do with those orange plastic things around a tree when you're taking out a bunch of trees. The antibodies attach to cells and mark them for other cells to destroy them. Natural killer cells, they kill cells. Non-Hodgkin's lymphoma, the vast majority of those involve the B cells. So I'm going to concentrate mostly on B-cell lymphomas. There are T-cell lymphomas, which are more rare. They're only about 15% of non-Hodgkin's lymphomas, and they're a little more complicated. So I'm going to stick to most of the B cells because that's where most of these are involved. Next slide. So if you have something that happens in the bone marrow that goes wrong with a stem cell, very early on when it's still making blood, it becomes leukemia. Later on, when things have moved to the lymph system and a B cell is affected, it can become lymphoma. At further stages of development, you can have other diseases like multiple myeloma and Waldenstrom's, Macroglobulinemia, that we're not going to go into. Next. And so lymphoma, as we talked about first, is a mass or growth in the lymph system. Next slide. Leukemia is cancer of the blood-forming cells, and it's a liquid kind of cancer. Next slide. The line between the two has maybe sounded a little confusing when I described it there. It's because it is. There is not a clear line between the two, okay? So leukemia has no oma, you don't have a mass. So with leukemia, you shouldn't get a mass, but oftentimes the same disease can really be a leukemia or a lymphoma. So small lymphocytic leukemia or chronic lymphocytic lymphoma, they're the same disease. Biologically, they're the same. Genetically, they're the same. When you look at it under a microscope and get special studies on those cells, they're the same thing. The only difference is if you get a mass. So if you have this disease, you have a large lymph node, you have chronic lymphocytic lymphoma. If you don't, you got small lymphocytic leukemia, and most hematologists just put a slash and say you sort of have both of them. The line is very gray between the two. Next slide. So how would you get non-Hodgkin's lymphoma? What sorts of things would give you or put you at increased risk for non-Hodgkin's lymphoma? Certain types of infections, so HIV, clearly puts you at high risk for lymphoma. Certain types of infections like hepatitis C will put you at higher risk for types of lymphoma. Immune suppression, so patients who've had organ transplants, you have to take drugs that suppress your immune system to keep your body from rejecting those organs. That puts you at increased risk for lymphoma. Autoimmune disorders, where your own immune system attacks parts of your body, actually also put you at increased risk for lymphoma. Interestingly, socioeconomic status is a risk for lymphoma. So people of higher socioeconomic status seem to get more of certain types of lymphoma. Some drugs, so if you give somebody chemotherapy, certain types of chemotherapy put people at higher risk for lymphoma, and treatments for other diseases that affect the immune system, such as some rheumatoid arthritis drugs that are great for rheumatoid arthritis, also put people at a little higher risk of lymphoma. Chemical exposures can, so organic solvents, toluene, benzene, NEC, stuff like that. Radiation exposure can increase people's chance of getting lymphoma. And breastfeeding may be protective if you were a baby. So, next. When you look at increased risk of cancer associated with radiation, there are a couple of classic studies that come up. Okay? So one of them is when they dropped atomic bombs on those folks, there was definitely an increased risk of lymphoma, Chernobyl, 3 Mile Island, and then the Los Alamos cancer study, which was when they looked at Los Alamos here from 1970 to 1990. It seems that there's a slightly increased risk of lymphoma in this community. And I say seems, and I'll go into that in a minute because I don't feel like this is absolutely definitive. But this line, so the black line, is is sort of the nationwide average for how much lymphoma there is. On the left is the incidence rate per 100,000 people, okay? On the right is the timeline, so this is your year, 72 to 90. And this line here is sort of the national expected rate. This sausage link line, that's New Mexico. This dotted, or the one with the dots here, that is Los Alamos, everybody. And then this solid line with dots is the non-Hispanic white population in Los Alamos. Now, you look at that line and you say, well, that is clearly, I may only be a nitwit physicist, but that line is clearly above this other line. What is complicated about this is these are very small numbers of patients, okay? So in a lot of years, they're sort of bordering around these years. And for that to be statistically significant is difficult to say. So here, in this period, there were, I think, 57% more cases than you would predict. But that's only 1 or 2 more cases. And so was that sporadic chance? Or is that because of potential radiation or chemical exposure? And that's where we don't know. Because we don't know how much radiation the people who got lymphoma were exposed to. We don't have that information. So it's very difficult to tell. And whether this is statistically significant, I would argue that it's not definitively statistically significant, even though the rate for some of this time was higher. Next slide. So from 86 to 90, the rate was clearly higher than we would expect. But when we look at the death rate, it was exactly what we would expect. Okay? And then when they did a later study, New Mexico Environmental Public Health monitors the number of cancer cases in the state. And from 2001 to 2005, the rate here, when you adjust for the age, was 16.9. The predicted rate is 15.8. Okay? So it's pretty close to where we would predict. I would say within the range of error. And it's not the most dangerous place to live for lymphoma in the state. Curry County had 20.9 cases. I don't know what's in Curry County. But I'll bet real estate is cheaper than here. Next slide. So if you get lymphoma, what do? Well, come see me. Or some sort of hematologist or oncologist. But it depends a lot on what kind of lymphoma you have. Because like this friend of mine's uncle who calls me up, the first thing you have to do is figure out what kind of lymphoma. So if we're talking about just non-Hodgkin's lymphomas, there are about 60 types of lymphoma, of non-Hodgkin's lymphoma. So you have to figure out what type of lymphoma you have. Then you got to figure out where it is. And there are a couple other things that can be helpful to figure out what to do. Next slide. This is a very small slide. Came out a little smaller than I hoped. But basically, we're going to break it into 2 big categories. Okay, so non-Hodgkin's lymphomas, there's a whole bunch of them, but there are aggressive ones. You can tell that because if you get it, and you think you have it, 2 weeks later, you're sure you have it because it's much bigger. Okay, so aggressive means that they grow quickly. Indolent subtypes means that they grow slowly. Okay, so indolent ones tend to be much more slow growing, aggressive ones tend to be much more quickly growing. And as you can see here, there's a bunch of different ones, and these are not all, this is not all inclusive. These are just the most common types of aggressive lymphomas include diffuse large B-cell lymphoma, mantle cell lymphoma, Burkitt's lymphomas, a whole bunch of other kind of lymphomas. The indolent subtypes, far and away the most common one is follicular lymphoma, and then there's a whole slew of others. Next one. So, slow-growing lymphomas generally are pretty sensitive to treatment. If you don't treat them, they tend to grow really slow, and we can't cure them. So with really slow-growing lymphomas, we know up front that we can't cure them. And since we know that, unless it's on a clinical trial with new drugs or new combination of drugs, we don't try, because the treatments can be rough if you try to cure it. On the flip side, we can give people very easy to take treatments for most of the, or for many of these types of lymphoma, and we can treat them for a really long time. And even better, sometimes we don't ever treat them. I mean, I have patients who have been followed for over 10 years with indolent lymphomas. We've never done it. So we just, you check them every couple months, nothing happens. Space that out, then it's every year, and they do fine. So there's a big range of what indolent means. Some of them are very slow. With more aggressive lymphomas, those folks don't do well if you don't treat them. So things tend to grow more quickly. But with the majority of those, the good thing is that we have a chance to cure them. So the most common type is, next slide. Oh, the most common type of indolent lymphoma, sorry, I can't see my notes, is follicular lymphoma, okay? So follicular lymphoma is 20% of non-Hodgkin's lymphomas. So for a lymphoma, it's pretty common. And you see about the incidence is a little over 2 people for 100,000 population per year. The median age of diagnosis is 60. And a small percentage of these will then, if you don't do anything to them, transform into aggressive lymphomas. But most of them are going to be very slow-growing lymphomas. Next. And the reason it's called follicular lymphoma is because it forms follicles, okay? These are much harder to pick out than those Reed-Sternberg cells. But, because a lot of things kind of look like this. But this is what a follicular lymphoma looks like under a microscope. Next slide. Diffuse large Bcell lymphomas are about 25% of non-Hodgkin's lymphomas. So they're actually even more common than follicular lymphomas. About 7 cases per 100,000 patients per year, or people per year. Average age of diagnosis is 64, and it's the most common of the aggressive lymphomas. It also is a type of lymphoma that has a bunch of different subtypes. So when somebody has a mediastinal lymphoma, there can be diffuse large B-cell lymphomas that start in your testicle. They can be in your central nervous system. They can be associated with HIV. There's a whole bunch of different diffuse large B-cell lymphomas, but they're a very common type of cancer, and they behave relatively similar. Next slide. So in order to figure out if somebody has lymphoma, they come to you with lymph node. You have to get a piece of it. The only way to really make the diagnosis for most of these types of lymphomas is to get a piece of tissue. You look at it under a microscope. So the way you get the tissue, you can put a needle in it, but with most of them, it's better to get a big piece of tissue. So if you have lymphoma, usually we'll want to cut that lymph node out if it's easy to get to. If it's hard to get to, we'll take a bigger needle and get a little bit bigger chunk of it. We also usually do a bone marrow biopsy to see if you have lymphoma in your bone marrow, because that's very common with a lot of these lymphomas. With some of the very aggressive types, we'll also want to get a sample of fluid from your central nervous system to see if there's lymphoma there, because some of these can go to your central nervous system. And we'll then put you through some tubes. We can get chest x-rays, is sort of a very old way to do it, but you generally now either get CT scans or PET scans to figure out where you have lymphoma. Okay? Because we don't want to, we can't cut open everywhere. That would not be good. And generally, we've moved more towards using PET scans, although in some cases we use CT scans. It depends a little bit on the lymphoma. Next slide. So stage is where the lymphoma is. And in most cancers, lower is better. So it's kind of, I don't play golf, but it's a little bit like golf. Other than it's all really good, I guess, to play golf. If your score is 4, you can't be mad. So stage 1 is localized disease. That means it's in one very small area. Okay, so that's the earliest stage. It would be very easy to radiate this area. And it's one region of lymph nodes. Next slide. Stage 2 is when you have 2 regions of lymph nodes, but they're close together. Okay? So they're like, your armpit, your chest, your armpit, your neck, things like that. And your bone marrow is not normal. Next slide. Stage 3 is when you use the diaphragm to find whether somebody has stage 3. If you have disease above and below your diaphragm, you have stage 3 disease. We now figure this out with CT scans and PET scans. We used to open everybody up. So if you got diagnosed with lymphoma, you had it above your diaphragm, you need to check above your diaphragm. We open you up, look around. It's a lot better to get a CAT scan. It's easier. So that's stage 3. Next. Stage 4 is when you have multiple organs involved, or if your bone marrow is involved. Okay? And that's the highest stage. All these stages have an A and a B. I mentioned really earlier on the B symptoms. The reason we call them B symptoms is because it changes your stage. You're A if you don't have those symptoms, B if you do. Next slide. More recently, we've realized that there are things other than what type of lymphoma and what stage you have that determine how well you are going to do. And a big part of that is how sick you look, right? I mean, I'm sure you've all looked at people and said, I don't know what's wrong with them. They don't look good. And this is just a really sophisticated way of doing a lot of that. So we look at people's age, and we look at their performance status, which with most cancers is really important, okay? So performance status means what can people do? Can they take care of themselves? Are they in a wheelchair? So it ranges from 0, which is totally normal. So you're working, you're living a normal life, to 1, which is not totally normal, to 2, which is you can take care of yourself, you're getting bathed, you're feeding yourself, but that's about it. And then 3 is where you're doing minimal activity, and 4 is basically dead now. So this is really important in looking at how people do. There are some blood levels that we look at. So LDH is a test that we get on patients to help figure out how likely they're going to have problems with treatment and how advanced their lymphoma is and predict how they're going to do in the future. And then we talk about stage and extranodal involvement. So people who have areas other than lymph nodes involved don't do quite as well. And there are a couple different things. So this is the International Prognostic Index. And we look at all these things together, and then we can help to predict how somebody's likely to do with their lymphoma. It helps to predict how well they're going to respond to treatment, but also how well they'll tolerate treatment. Next slide. So these are the numbers. So, obviously you'd rather have fewer risk factors. 0 to 1's good. 4 to 5 is bad. 2 to 3 is intermediate. Okay. Next. This is the Flippy score. Has a cool name. Same thing, really. But it's for follicular lymphomas or indolent slow-growing lymphomas. And it also has an acronym, no lash. Didn't help me remember, really. But it's the number of lymph nodes people have. It's that lab test that we talked about, the LDH. It's people's age. So people who are under 60 years old tend to do better than people who are over 60 years old. Their stage. And then whether or not they have anemia. So the hemoglobin. Patients who have low hemoglobin tend not to do as well because that signals that they are sicker and likely that their bone marrow may be more involved. And it's the same thing. You'd rather have 0 or 1. 3 to 5, not as good. Next slide. So now we're also working on newer things that may help us to predict who's likely to respond to therapy, who's not likely to respond to therapy. There are a lot of genetic tests that we're looking at and gene expression to help figure out who is going to benefit from therapies we have now, who maybe isn't, and would be better to look at a clinical trial early on. Bcell2 and Bcell6 are some things that we're using intermittently in the real world, and in the research setting, there's a lot of new work going on with this sort of stuff. Next slide. So, in order to properly treat somebody's lymphoma, you need to know what kind of lymphoma they have, whether it's indolent or aggressive. You need to know where their disease is. You need to look at their prognostic index score, which is a little bit more global look at things associated with their lymphoma. And there are some other things like extranodal involvement and their age that can influence that as well. Next slide. So what do we do for treatment? Well, there's a whole bunch of different stuff. But it all sort of goes down into one of 4 categories. Radiation is good for small areas of disease. Chemotherapy treats everywhere. So chemotherapy is what we use for most lymphomas because most lymphomas aren't in one small area when we meet the patient. There's immunotherapy, which uses the immune system to help fight the disease. And then there's stem cell transplant, which I'm not going to talk about a whole lot, but when these other therapies are less effective, sometimes we'll give people very high doses of chemotherapy or radiation. We'll actually take some of their bone marrow or somebody else's bone marrow and give it back to them after they've had high doses of chemotherapy or radiation. Because in order to give those high doses, you would destroy their regular bone marrow. So we can use that in some cases. Next slide. For aggressive lymphomas, clinical trials are always an option. So if there are new drugs, we're always trying to do what we do better. And we're always looking at new clinical trials with new drugs. But most of the time, we're going to use chemotherapy. And the most commonly used chemotherapy is something called CHOP-R, or R-CHOP, okay? Not as cool as the karate chop. But that is an acronym for a couple different drugs, and I'll go into that in a little bit of details. We will also sometimes use radiation therapy, and sometimes we'll use stem cell transplantation when we know that patients are not going to do well with chemotherapy alone. Next slide. So, monoclonal antibodies. We talked about how your body, these B cells, make antibodies that bind on the cells to mark them to be destroyed. Well, we've now learned how to use these tricks against lymphoma. One of the ways we identify lymphoma is by finding proteins on the surface of these cells. It's called an antigen. And they've actually manufactured antibodies that bind onto those. And so they bind onto the lymphoma cells and mark them to be destroyed by your immune system. Okay? Next slide. Far and away the most common of these is a drug called rituximab. And is an antibody against a protein on the lymphoma cells, and it marks it so that your immune system then comes in and destroys a certain percentage of those. It's the R in R-CHOP, or CHOP-R. Next slide. So chemotherapy works well against rapidly dividing cells, okay? All rapidly dividing cells. So it has a lot more side effects in other parts of your body. Antibodies are targeted towards specific cells, and so they have fewer side effects in the rest of your body and can still be very effective for treatment. Next slide. But the best way to use them is generally together. So when patients with curable lymphomas or indolent non-curable lymphomas get both chemotherapy and some type of immune-mediated therapy, like an antibody, they work well together. Hence, CHOP-R. So CHOP is cytoxan, adriamycin, oncomycin, and prednisone. That's the CHOP. And then the R is the rituximab. It's that monoclonal antibody. And using them together, they work better than using them separately. Next slide. So for slow-growing lymphomas, it's kind of similar. We will use similar drugs, but we oftentimes will use fewer drugs, drugs that are a little bit less effective or less toxic, because we know we're not going to cure it. And we know that years later, you may have to treat that lymphoma again. Okay? Next slide. So there are two types of monoclonal antibodies. We talked about the ones that just label these for destruction. That's the rituximab, or what we call unconjugated antibodies. So this thing here, that's an antibody. It is attaching onto this antigen or protein on the tumor cell, and it's not noticing this normal cell. Okay? So these are tagging that for destruction by the immune system. Next slide. They now have antibodies that are attached to radiation. So they have, this is a normal antibody here attached to the cell, but they have cells that are attached to isotopes of certain elements. So we're able to actually deliver radiation to individual cells involved in the lymphoma. Next slide. These are the two that are commercially available. Ibrituximab TXMab. Yeah. That's why nobody talks about drugs in generics. They make it too hard to pronounce. And then the other one is iodine 131, or tazotuzumab. And both of these have radiation attached to the antibody. They're good for second and third line therapy in patients who've already had therapy. Next. So lymphoma, overall, if you look at it from when we start 1666 to now, is, relatively speaking, an oncologic success story. We're still getting better treatments, and we're always trying to improve what we do now, make it less toxic and more effective. We have new drugs that people are in development that hopefully are going to improve the treatment that we have today. Next slide. But if you look at the really big picture, lymphoma is a small part of it. Non-Hodgkin's lymphoma, and Hodgkin's doesn't even make this list. Non-Hodgkin's lymphoma, when you look at cancer deaths, and part of this is because their treatment is so good, but it's only 3% of cancer deaths in both men and women. Okay? If you look at number one, 31% of men, lung and bronchus cancer, 26% of women, lung and bronchus cancer. Next slide. And so what you can do is if you have friends who smoke, tell them you love them, try to support them. And you know, smoking is still the #1 preventable cause of death in America, no matter where you live. So it's something to keep working on from a public health standpoint. Next slide. Thanks. Okay, so everybody got that? There's a quiz. Questions?
Thank you very much. That was great. We do have time for questions. I'd like to pass the microphone around so we can hear your question.
I'd like to know if high doses of prednisone treatment causes cataracts to grow.
High doses of any steroids will increase your risk of developing cataracts over time. So steroids increase your risk of getting cataracts. Generally, that's with chronic exposure. So if you're taking it regularly, yes. The doses that we use with chemotherapy would slightly increase your risk of cataract formation, but it shouldn't be a very big increase in risk because we're giving people, you know, if you get 6 cycles of chemotherapy, 30 doses of, of a steroid at most, it will slightly increase your risk, but not significantly. It's people who are chronically on steroids that are really high risk to get cataracts.
Thank you. I have just 2 more.
Yeah.
Why is it important to treat dormant hepatitis B when receiving the rituximab chemotherapy?
Yeah, that's a very good question. So hepatitis B is a viral infection of the liver, and it can exist in 2 forms. You can get acute hepatitis where people are very sick, they turn yellow, they get really ill, or you can have chronic infection that you never know you have. When we treat people with rituximab, a certain percentage of those folks with hepatitis B will get, it's not reinfected because they're already infected, they get reactivation of that virus, and they will then get acute hepatitis. They can get very, very sick with that. And so we test people prior to using rituximab because in the treatment of those lymphomas, rituximab increases the cure rate, but you're probably better off not getting it if you have hepatitis B infection.
Thank you. My last question is, in your studies with non-Hodgkin's lymphoma, what do you find areas of different regions with high population and overcrowding with automobiles like in Asia, they're higher incidences and numbers? Very high.
Lymphoma is not really well understood. In crowded areas, I'm trying to think. So if you look at places that have extraordinarily low lymphoma rates, Denmark. Move to Denmark. You don't get lymphoma. I mean, nobody knows why. And some of the things that you would expect to increase your risk don't. And that probably has to do with, while there are infections that increase your risk, a lot of common childhood illnesses actually decrease your risk. So while Epstein-Barr virus will increase your risk, getting measles, mumps, rubella, those things decrease your risk. And people who are of higher socioeconomic status actually seem to be at higher risk of non-Hodgkin's lymphoma than people with lower socioeconomic status. So it may be because they're exposed to fewer, less infections, less dirt, and it goes the opposite, you would think, with socioeconomic status. So I'd say I can't speak for crowding specifically,
yes,
but I generally think of people with lower socioeconomic status as often living in more crowded urban areas, and that seems to be effective.
thank you very much.
Yeah.
Other questions?
The question was, why does the Epstein-Barr virus increase the risk of getting Hodgkin's disease or Hodgkin's lymphoma? I don't think it's a no. It's been it was something we discovered backwards. So they looked at people who had Hodgkin's lymphoma and they were trying to figure out why they would get it. And folks who have Hodgkin's lymphoma are much more likely to have previously been infected with Epstein-Barr virus. There are a lot of theories that we don't really know.
Other questions?
You said that smoking could be an increased risk. Does that include marijuana?
It's a little harder to study marijuana because people are perhaps less forthcoming about their consumption. So for the most part, there are some differences in marijuana and tobacco, THC primarily. But when we look at lung cancer, but the majority of it, it's a plant that you're smoking, okay? And most of the chemicals that come off there are actually very similar to cigarettes. So when we look at lung cancer risk, which is what I use as a surrogate because we don't have data for lymphoma, but with lung cancer, we know things that cause cancer come from cigarettes. And that has been compared with marijuana. And smoking marijuana, generally a joint a day, which is a cigarette of marijuana, for those of you who haven't watched the movies lately. A cigarette a day of marijuana is essentially equivalent to a pack of cigarettes. And everybody says that when I go, wow, you know, and they go, so you are like, you're with the man trying to keep less down, aren't you? I came from Florida, where, you know, where they're arguing about putting marijuana in the water. The reason for that is probably not because the compounds are that different. The advantage of marijuana from a safety standpoint is it's a lot harder to smoke a pack of marijuana. You can't just walk around and work all day and smoke. But the way that people smoke marijuana is different than the way they smoke cigarettes. So I used to think that cigarettes were sort of the ultimate drug delivery system to cause cancer. Wow. You know, it gets deep into your lungs, it stays there for a long time, and it gets rid of the part of the immune system that cleans that out. And people buy it for decades, and then they get the disease. You know, it's really a brilliant way to cause cancer, but marijuana is arguably better because of how people smoke it. They take it deep in their lungs, and then they hold it there, and then they let it out. So in studies that they've done looking at marijuana and lung cancer, a joint a day is equivalent to a pack a day. And I would infer that that's probably going to be true for lymphoma, but nobody really knows.
I had a friend in college in the 70s, and she had Hodgkins disease, and they treated it, this was kind of in the beginning, you know, and they treated it with radiation and chemo, and I always wondered, they, through the radiation, from what I understand, she became paralyzed from the shoulders down, or the armpits down. What caused that, as far as you could imagine?
So with radiation exposure, the damage to an organ varies with the dose, okay? So if you give somebody a high enough dose of radiation, you kill them. And with each part of your body, if you give them a high enough dose, you will severely damage that part. Now, a long time ago, radiation was kind of like a flashlight. You know, you just shine it at somebody and you radiate. Today, and I gotta be really careful. Radiation is much cooler. So the way that we design people's radiation treatment, instead of being one ray, it is a whole bunch of different beams, and we're able to curve them, we're able to shape them, so that we get high doses of radiation to the tumor and low doses of radiation to important structures. One of the most important that I can think of is the spine. So with more primitive radiation techniques, in order to know that you were treating a tumor, you put the spine at risk because you didn't have a way to do different doses next to each other. Today, we have very sophisticated ways of planning radiation that will make it very unlikely that you would get problems like that. So that's something you used to see back in the 70s and you essentially don't see today.
She ended up dying 10 years later from leukemia.
And patients who've been treated for lymphoma have an increased risk of developing leukemia. It's probably partly because of the drugs we give them, but it's also partly because something went wrong in the system in the first place. So those are folks that, you know, may have had a predisposition to that genetically.
Eric, I follow several patients, quite a few patients over the years with chronic lymphocytic leukemia. Is that a more common type or chronic lymphocytic lymphoma?
Yeah.
Are those more common than some of the other mantle cells and so forth?
It's fairly common, and the incidence of that isn't that high, but its prevalence is very high. The reason is, what that means is that we see some cases in the population, not a tremendous number, but those folks live for a long time. So each year you diagnose a certain number of people, you're not going to have a lot of people with the disease that they all die of. With chronic lymphocytic leukemia, not many of those folks die. You say you followed for a long time, and you probably didn't do anything about it, right? You just watch it. And you get the occasional call, hey, your patient's in the emergency room, their white count is 45,000. And you go, yeah, I know. It was 45,000 last month and last year, and they're okay. You know, what are they there for? Strep throat. Okay. Yeah, they don't need to be in the ER. Big deal. So it's something that is fairly common. The other thing is it's a disease that is more common as you get older. So we're getting more of an aging population, so we see more of it. Okay, well, thanks for coming, Mel. Appreciate it.